Hello, everyone. Greetings from the University of South Florida in Tampa. Please note this session is being recorded. Thank you for joining us for this regional session of our Global Health Conversation series. I'm Lynette Menezes, and I oversee global programs for USF Health, which consists of the Colleges of Medicine, Nursing, Public Health, and Pharmacy. On behalf of USF Health International and the Global Virus Network, I want to warmly welcome each of you, especially our colleagues from Sierra Leone and other parts of Africa. As we continue to move into the next phase of the COVID-19 pandemic, which has just dominated the news for so long, and our daily lives and the field of global health, it is time now for us to begin to refocus our efforts on other critical public health problems. So today, our distinguished speakers will be talking to you on a huge public health problem that we have in terms of mortality, child mortality in Sierra Leone. So the topic of our conversation today is, if you can't measure it, you can't manage it. Could mortality surveillance serve as an entry point to reduce under 5 deaths in Sierra Leone? Our distinguished speakers today are Dr. Cheedy Jaja, who will be first talking and will moderate this discussion. And our second speaker today will be Dr. Ikechukwu Ogbuanu from Sierra Leone. Dr. Cheedy, I'm going to go ahead and introduce Dr. Cheedy Jaja, and Dr. Jaja will then introduce Dr. Ikechukwu Ogbuanu. Dr. Cheedy Jaja is an associate professor in the College of Nursing at the University of South Florida. He's also an adjunct research faculty member in the Department of Emergency Medicine at Augusta University, Augusta, Georgia, and the College of Medicine and Health Sciences at the University of Sierra Leone. Dr. Jaja is also the Assistant Dean for Global Community Engagement at the College of Nursing in the University of South Florida. He has many years of experience providing clinical and psychosocial care, primarily to patients with sickle cell disease in ambulatory healthcare settings. And his teaching experiences span over 3 decades across nursing, social sciences, arts, and humanities in higher education institutions. Dr. Jaja also has several NIH grants where he does his work in Sierra Leone, in Freetown, and in Kono, and has notably had many years of experience working with institutions across Africa as well. So with that, I will have Dr. Jaja take the stage now.
Thank you so much, Dr. Menendez, for that glorious and wonderful introduction. I'm Cheedy Jaja, and it's indeed a pleasure to be part of this Global Health Conversation series. And it's indeed a double pleasure for me to introduce the work that's been done by my able colleague and good friend, Dr. Ikechukwu Ogbuanu in Sierra Leone. Okay. To set the stage, I will just give a basic background about Sierra Leone, the work that we're doing in Sierra Leone, and how it dovetails with the presentation that Dr. Ogbuanu is going to present today. Okay. So in Sierra Leone, over the last 4 years, we've been engaged with several partners in developing public health, health system capacity building project, health system strengthening and capacity building project with specific focus around sickle cell disease. Our partners involve institutions here in the United States, namely Augusta University, Duke University, and federally qualified healthcare center called Jericho Road Community Health Center that runs a major hospital in Sierra Leone that we use as our research site as well as our medical center. Okay. In Sierra Leone, we work with the main university teaching hospital and medical school, as well as the newly formed Postgraduate College of Nursing and Midwifery. So together with his partners, we're involved in creating a framework whereby children with sickle cell disease can be diagnosed early at birth and then managed throughout the first 5 years of life. And you'll see as I move on to my next slide why this is important. Okay. So Sierra Leone, for those who don't know, is a small country on the west coast of Africa, and it has a population of about 7 million. Okay. Usually when Sierra Leone is in news, it's always negative. And I say that because it's a country that endured 10 years of very brutal civil war. And in 2014, 2016, it was one of 3 countries that had endured the Ebola epidemic. And what this has caused for the country is not only a massive drain, but both the Civil War and the Ebola epidemic resulted in a massive brain drain when majority of the middle class had to leave the country to seek greener pastures elsewhere. And the Civil War and the Ebola crisis result in a healthcare system that is almost fragile, to say the least. Okay. My work, as I mentioned earlier, centers on sickle cell disease. This, in spite of a small size, Sierra Leone has one of the heaviest sickle cell burden in sub-Saharan Africa. Each year, approximately 4,000 to 5,000 children are born with sickle cell disease. But because of the fragile healthcare system, majority of these children would die. Between 50 to 90% of these children would die before their 5th birthday. So the work that Dr. Ogbuanu and his team are doing in Sierra Leone is very germane to our project as well, because his team are looking at the causes of under-5 mortality in the country. So I am not going to steal his thunder. I'm not going to say what he's going to say, but what I'll do is I'll tell you a bit about his impressive pedigree to set the stage for his talk. Okay. Dr. Ogbuanu is a medical doctor and an epidemiologist with more than 20 years of progressive experience in clinical medicine, academic research, and global public health, vaccinology, leadership, and management. He has published a lot. He has a very impressive peer-reviewed publication record in HIV/AIDS, vaccine-preventable disease, and genetic epidemiology. He also has substantial clinical and programmatic experience in the control of tropical and infectious disease at the global, national, subnational, and health facility level. Okay. Dr. Ogbuanu joined the U.S. Center for Disease Control and Prevention, CDC, in 2009 as an Epidemic Intelligence Service Officer. Okay. He had worked at the CDC headquarters in Atlanta and also worked as a detailee to the World Health Organization in Geneva. Okay. During this period, Dr. Ogbuanu has acquired advanced implementation research and policy experience at the global level through qualitative and quantitative health research, program design, implementation, technical policy development, and international health diplomacy. He had led and participated in multiple global multilateral working group and sub-team, and he has successfully managed collaboration and provided direct technical support in Africa, in Asia, Western Pacific, Eastern Mediterranean, Europe, and the Americas. So Dr. Ogbuanu has been all over the place, okay? His work has also been recognized. He's a recipient of multiple awards, including the US J. Sue Arnold Alumni Award in 2019, the CDC Excellence in Public Health Services Award in 2014, the CDC Award for Excellence in Public Health Protection. I could just go on and on and on. Like I said, he has one of the most impressive pedigree that I've ever encountered. So without much ado, it's my pleasure to introduce my colleague and very good friend, Dr. Ogbuanu.
Thank you so much, Cheedy, for the very kind introduction, and welcome everyone to our presentation today. Jesse, I just want to confirm that you can see my screen, can you?
Yes, yes, we can.
I can see it.
Okay, great. So like we've been told, we will spend the next 40 minutes or so talking through my slides, and then we reserve some time at the end for questions. We said if you can't measure it, you can't manage it. How could mortality surveillance serve as an entry point to reduce under 5 deaths in Sierra Leone? I would be presenting based on this outline. What is CHAMPS? To give a flavor for those who may not be very familiar with the CHAMPS project. And then why CHAMPS? Give you some background on the methodology we use for our data collection to just ground people on the potential this methodology holds, and then present some findings that are driving local impact, and then what causes of death are the biggest contributors, and this would be preliminary data, obviously, and then looking at how we can explore opportunities for future collaboration between CHAMPS and USF. You will see on my next slide, the CHAMPS stands for Child Health and Mortality Prevention Surveillance. This is a network of surveillance sites in sub-Saharan Africa and South Asia. You will notice in Western Africa, where Sierra Leone is located, there are 2 sites in Mali and in Sierra Leone. In Sierra Leone, we have 2 sub-sites, one in Makeni and one in Bo. In Eastern Africa, we have Ethiopia and Kenya, and in Southern Africa, Mozambique and South Africa. There is an active site in Bangladesh and an upcoming site in India. We are a network of surveillance sites that are funded by the BMGF, the Gates Foundation, with our program office located at the Emory University in Atlanta. As a network, we have 3 overarching objectives. One is to track definitive causes of child mortality in sites throughout sub-Saharan Africa and South Asia using what we call minimally invasive tissue sampling, and I will go a little bit into that for context. Secondly, we want to produce and disseminate high-quality data to inform policy and public health action, and ultimately to enable sites to leverage CHAMPS investments to prevent mortality. CHAMPS is big on data to action, and the hope is that CHAMPS data will help inform a range of public health decisions, including policy changes to change children's lives. And these changes will happen at a local level, it is hoped, and this includes households, communities, health clinics, local and traditional leaders. At the national level, we work across these sites with ministries of health, with national public health institutes, hopefully to both incentivize and support country ownership and long-term sustainability. At international level, CHAMPS works really hard to build partnerships and networks to disseminate data, to share knowledge, and to catalyze action. So that's what CHAMPS is, but why CHAMPS? And at this time, 2019, and year on year since then, more than 5 million children die before their 5th birthday. Roughly 14,000 under 5 days occur every day, including today, but almost half of this occur in the first month of life. More than half of the causes of death are preventable or treatable with simple, affordable, and known interventions. But the causes of deaths often remain unknown due to gaps in disease surveillance, and especially in a poorly resourced setting like ours, there are rarely postmortems that are taking place because, of course, complete diagnostic autopsies require both expertise and resources. So current disease burden estimates are largely based on verbal autopsies and registries where they exist, and there is therefore persistent poor access to evidence-based health policy. So what does CHAMPS do? We therefore come in to identify those definitive causes of death and therefore find ways to prevent them. And I'll be trying to make that link in my talk today. We do this through strong community engagement, through sensitive mortality surveillance, through diagnostic and laboratory innovations, and through data to action, like I mentioned in my previous slide, but also rapid open access to data, which I do think would be one way that our collaboration with the university could actually take off. Here is the way we are organized globally. And at each site, you will see from the top, we have the Global Partners Board and the Program Office at Emory with IAMFI and CDC and the Public Health Informatics Institute participating. At the country level, we typically have 1 or 2 implementers at each site. In Sierra Leone, we have much more, World Hope, It's an international NGO. Focus is a local NGO. CDC is US CDC in Atlanta. And Crown Agents, which is where I sit. So Crown Agents works very closely in Sierra Leone with the government of Sierra Leone at the top as a co-director providing overall supervision, while Crown Agents is a primary fund recipient and therefore serve as co-director for the project. So I am the co-director with our Ministry of Health partner, and we conduct both fiscal management and technical oversight, but also lead the lab, data, and informatics pieces of the work. Focus 1000 is engaged mostly around social behavioral science, while World Hope International leads the mortality surveillance piece. In Sierra Leone, like I mentioned earlier on, we have 2 sites in 2 out of the 16 districts in Bombali and Bo districts. And this is the map of Sierra Leone, like you can see here. And in the northern part, we have the Bombali site. In the southern part, we have the Bo site. CHAMPS has been around since at least 2017. In 2017, we started some of the social behavioral work and community engagement work. And in 2018, we actually started some piloting of reporting, which was not existent outside of the Ebola situation that had just been over at the time. In 2019 was when we started minimally invasive tissue sampling, which is the autopsy that I will be dwelling on a little bit more. And in October of the same year, we started what we call determination of cause of death, which is a panel of experts. Again, I'll give you more details in a future slide. In 2020, our focus has been on data to action around what public health actions can actually reduce child mortality. And beginning last year and going forward, our emphasis and our hope is to collaborate with institutions such as yours and other funders to drive impact on child mortality. It's important because you can see in this slide, over the last 40 years plus, we have made progress in terms of reducing child mortality. On the y-axis is the share of newborns who died before reaching the age of 5. And on the x-axis are the years. Within 1960, about 5% of kids were dying before age 5. And by 2017, this number came down between 5 to 10%. Tremendous progress. But I think I want us to notice 2 things. One is that the progress hasn't been uniform across countries. I've added Guinea and Liberia here, which are neighboring countries to Sierra Leone. And these are having, about 7 to 8% of, mortality, if you will, by the age of 5, compared to Sierra Leone, which is about 11%. But even when you compare to Malawi, which is another country in Africa, with similar, actually lower resources than Sierra Leone, you will see that that's about half the child mortality rate as Sierra Leone. And that typically leads me to discuss this slide, which on the y-axis shows the child mortality in a log scale per 1,000 live births. And on the x-axis, GDP per capita, that's income. Each bubble here is a country. The color of the bubble shows the region of the world. For the blues, for example, African countries, the reds are Asian, and so on. And the size of the bubble is the population of the country. So this would be, for example, China, and the other bubble lower down here would be India. We'll notice, for example, that as GDP per capita increases, mortality generally goes down. Therefore, Singapore is quite low, about 3. United States, you see there, about 5. So really impressive relationship between child mortality and GDP per capita. Here is Sierra Leone, which by this measure on this graph is about 109 actually. And so you see that because it's a poor country, you would wish that if it were to develop further and increase GDP per capita, you would therefore drive down mortality. But I wanted to see 2 deviants. One is the negative deviant. So here is Nigeria. Nigeria has at least 3 times the GDP per capita of Sierra Leone, but it has a higher, child mortality than Sierra Leone. And we can go into reasons why. We don't have time on this discussion, this presentation, but happy to when we enter the discussion phase. The positive deviant, however, is Malawi. Malawi is a poorer country by this measure, but has about half the child mortality of Sierra Leone. I think the question we always ask ourselves when we discuss with our collaborators on the government side is, And what is Malawi doing different from Sierra Leone that we can learn from to further drive down mortality? And sometimes these are very difficult questions to answer, and there may be no clear answer, which is why I like to start with these kinds of stories. So this event I'm going to describe happened in 2019. This is one of our cases where we conducted a verbal autopsy, and therefore we asked the caregivers the circumstances of the death. And you would see from this example that, for me, one lesson is that small changes can make a huge difference around leadership, including feedback loops, but also, ongoing training and support within each health facility, in this case, the McKinney Regional Hospital. So this is the summary of his ex. And this is what the husband said. He said, my wife started in labor, but she was reluctant to go to the hospital. Around midnight, labor pain increased. I took her to the hospital and she was admitted at the maternity ward. IV fluids and injections were given. The next day, delivery started with a stock head after the lower extremities were delivered, only remaining the head to be delivered. I requested for CS, but the doctor was not around, and the SACHO, this is the assistant clinical health officer, surgical, was also in surgery, came as quickly as possible. Finally, when the doctor came, then my wife was taken to theater and delivered a dead fetus at 4:30 p.m. had hydrocephalus. Just after delivery, my wife started bleeding and the doctor ordered for blood. But before the transfusion, she passed off at around 7 p.m. So here is the husband, lost the baby and also lost the mother. And we always use this to ask ourselves several questions. One is, why was this mother reluctant to go to the hospital? Was it financial impediment to care, or was it the way she expected to be treated, or has she had some bad outcomes in the past for herself or for her neighbors? The head was stuck. Why should that happen if there was proper antenatal care with prenatal diagnostics performed? Doctor was not around. In many of these places, there's only one or two doctors who can perform these kinds of procedures. So we do not expect them to be there 100% of the time. But why were they not there? Could we have more trained doctors? There was hydrocephalus, which is not a death sentence in more developed climes. And so why should this child die just because there was hydrocephalus? And before the transfusion could be conducted, this child passed off. In many of these clinics, there is no blood bank. And parents typically have to donate blood and have to be lucky to be correctly matched in order to have transfusions and in good time. But for this particular mother who may be suffering from some kind of complications, maybe DIC or similar, she bled to death. Putting that in context, and I'll come back to that on data to action, was our methodology in CHAMPS. So if you start from the bottom of this slide on the left, we typically engage communities through what we call social behavioral science. And then we have a system to detect cases through a notification system and collect the samples needed, and hopefully additional AP data, including clinical abstraction data, verbal autopsy, and initial autopsy data. We identify the pathogens in the lab, and then we analyze the tissues for histopathological diagnostics and assign a cost of this through a decode panel, ultimately to be able to reduce mortality. Here are the samples we collect in general. On the top are the fluids, blood, CSF, nasal and oropharyngeal swab and stool. And at the bottom, liver, lung, heart, brain, and placenta when available, and obviously especially for Hubert's. And we collect all these samples, obviously, like I've said earlier, through minimally invasive tissue sampling. And for those who are involved or interested in autopsies, CDAs, complete diagnostic autopsies, will remain the gold standard, I believe. However, they're expensive. They substantially delay time to burial, and they can present cultural barriers. So there is promise in a quicker, less expensive, non-disfiguring, needle-based sampling approach that is called MITS or MIA, which has been well accepted to both parents and communities and has reasonably high correlation between MITS and CDA, especially for infectious diseases. So if you're involved in disease body estimates, for example, you will know that most of those are done through vaccinology on my left here in blue. And they have known limitations, which CHAMPS is trying to close. For a VA, you interview the caregiver and either a physician or some kind of algorithm helps to determine the cause of death. In CHAMPS, we do interview the caregivers through a VA, but also a social autopsy. And then we gather a panel of experts to review each of the cases. But in addition to that, the experts now have post-mortem lab specimens available. Therefore, we are able to assign a specific cause of illness down to the particular organism, for example, causing a pneumonia death, and whether or not they were sensitive to known antibiotics. Here is all the data that we collect. On the bottom here, I've just mentioned the mixed data and other diagnostics, and this includes sickle cell testing, and then pathology results from both site pathology and the CDC pathology. And on the top here, TAC results. These are PCR results. On the blue are demographic data, viral autopsy data, clinical abstraction, and maternal records. And we present this to a panel consisting of pediatricians, microbiologists, pathologists, epidemiologists, and neonatologists and OBGYNs as relevant. And then they assign a cause of death using the ICD-10 and ICD-PM methodology. And this is a typical certificate, WHO death certificate. And on the top, you will see that the cause of death typically is at the bottom here where you have the underlying cause of death. For most VA and GBD data, you will have one cause of death, underlying cause of death. For CHAMPS, we tend to then assign all the other causes of death, i.e. what was the immediate cause of death, and that was due to some intermediate causes of death. If you look at the bottom of my slide here, you will see that all of these are in the causal chain. The immediate cause of death is the disease or complication which directly preceded or directly led to death. There may be other morbid causes in between before D, which is the underlying cause of death. This is a disease or injury that initiated the train of events leading directly to death, or circumstances of accident or violence which produce the fatal injury. And in part 2 of the form, we also include other significant conditions that may have contributed to the death, but are not necessarily in the causal pathway. So why don't I show you some results? So in the period where we've collected data so far, on the top, you will see that we have more than 2,500 unique notifications so far from about 6% of those are community deaths. The focus of most of my presentation will be around the myths. These are cases, 434 of them, where we actually conduct the autopsy. We are eligible. The death has to have resided in the catchment area for the preceding 4 months, has to either be a confirmed stillbirth or less than 60 months of age. Of course, the body needs to be available, and it needs to be less than 24 hours between death and eligibility screening and or consent. So far, CHAMPS has collected deaths, about 2,500 deaths, and we have coded about 210 of those. So we have sent these cases and packets to the panel of experts, and we provided 91% family feedback to those that have been decoded. Just in terms of the initial breakdown, these are number of myths by gender and age, 434 total, like you saw in the previous slide. First, I want you to notice is the high number of deaths, about 55% of them occurring between day 0 and day 27 of birth. Again, coming back to this as a potential intervention in terms of how we think about future work together, but there doesn't appear to be any interesting gender difference. Of these cases, we have now run them through the decode panel, and they have assigned specific causes of death. I will try to go through this in terms of different classifications. And for stillbirths, and for each of the next 5 slides, look at the bottom. The reds are communicable diseases. We have grouped them together. The blue are the maternal, neonatal, and nutritional causes of death. The greens are non-communicable, and the gray are undetermined. So you will see that for stillbirths, instead of underlying cause of the majority, more than 93%, are due to maternal, neonatal, and nutritional causes. But a huge proportion of that is it intrauterine hypoxia. There is also congenital malformation, 2 cases, and encephaly specifically, 2 cases already seen, and the spinal bifida as well, 1 case. So I think it's interesting for those who are interested in how we discuss what this might mean for future collaborations. But for neonates, so you're looking at the slide now for neonates. So I will show you the underlying cause of death and then the immediate cause of death. For neonates, we see a lot of blue again. So what was the primary thing that initiated a series of events that ultimately led to death? We see a lot of birth asphyxia, a lot of intrauterine hypoxia, prematurity, congenital malformation, RDS, low birth weight, prone belly syndrome, making aspiration. So we have to highlight in spite of them being, for example, belly syndrome, part of congenital malformation, because we have seen a lot of these cases. I want to be able to delve more with the government and why this could be happening, there are different things we could be doing in terms of interventions. You see a small proportion of underlying causes that due to sepsis, pneumonia, respiration pneumonia, due to infectious or communicable causes. But when you look at the immediate cause of death, so what's the final insult that finally leads to death? We've seen about 55% of those are now due to infectious causes, like you can see on this slide. So pneumonia, sepsis, meningitis, fungal encephalitis, and other candidiasis, much more represented. For infants and children, from day 28 all the way to month 59, we are seeing a lot more infectious causes of death for underlying cause of death. Most of us would have expected to see malaria, and yes, here is malaria, and there is pneumonia, but not as much as gastro as people may have expected, both in this slide and when we look at the immediate cause of death, but a huge proportion of malnutrition as a cause of underlying cause of death in infants and children. For infants and children, for immediate cause of death, we see a greater representation of infectious or communicable causes. So this means, for example, that a child may have an underlying malnutrition, but that the final insult that actually kills them would either be, for example, sepsis or pneumonia or malaria. There's gastroenteritis, but again, not to the extent we had expected. And finally, on this slide, you will see a lot of acute liver injury that we associate with some use of herbal medications in some of these settings. Finally, in terms of results, I wanted to show you the main maternal conditions that are associated with these deaths. Again, the focus is on child health, but you will notice maternal hypertension disorders are resulting in a lot of the, obviously, the hypoxias and the issues around death during delivery and obstetric care. Malpresentation of labor, chorioamnionitis, placenta disorders, and APH. Let me just dwell a little bit on malnutrition as an underlying and or immediate cause of death. So anywhere in the causal pathway of the decoded cases, you will see that about 130 cases so far among the 210 we have decoded have malnutrition somewhere in the causal pathway. And that translates about 46%. So nearly half of all the causes of death have something to do with malnutrition. And for cases where malnutrition was an underlying cause, the leading comorbid conditions are as listed below, including anemia, sepsis, malaria, pneumonia, gastroenteritis, bronchopneumonia, sickle cell disease, meningitis, and viral bronchiolitis. Then I'll just show you some more specific slides, and then we're going to switch gears to prevention. So common pathogens are associated with infectious underlying cause of death. You will see at the bottom here, malaria, so Plasmodium falciparum, an important contributor, as well as pneumonia. We're seeing a lot of these in the neonatal age group, and HIV. And this, again, is for underlying cause of death. But for immediate cause of death, again, on common pathogens, we are seeing pneumonia as a final insult, and pneumonia and Plasmodium falciparum, and others less so. Switching gears in terms of preventability, I think, again, like we said at the beginning, if you can't measure it, you really can't manage it. But measuring it is one part of the puzzle, because many of the concerns that we are seeing actually systemic. And I thought I would show this example where access to prompt and quality healthcare services can actually make a big difference, but there continue to be socioeconomic barriers, and there are opportunities for health partners, for local support, but also for collaboration such as yours to try to delve into some of these issues. So in this case, it's why it's a 15-day-old neonate. The mother said, my baby had fever throughout Tuesday night. I took him to hospital on Wednesday for treatment. At the facility, he was admitted. Treatment and oxygen were given, but I had to buy 9 cannulas to aid the treatment. Fever continued, followed by convulsion. The nurses asked us to buy medicine and a cup for breast milk, which added up to 85,000 leons. That's about $8. My sister and I told them that we didn't have that amount, but we begged them to continue treatment and we'll pay later, but they were not willing to accept. Someone had to lend us some amount and we had to pay the sum that was available before they started treatment. After which we were asked to wait outside of the ward while they treated the baby, and I squeezed breast milk into a cup for the nurses to feed the child. My child died later that day. I was asked by the mortuary to pay 150,000 leons, which is about $15, in order to release the body. So this mother had to buy the cannulas for the treatment. They had to buy the medicine. They had to buy the cup for the breast milk. $85,008 may not look like much to you, but many of our patients here do not have that amount on hand, especially in the context of a free healthcare provision that's supposed to be available in the country. So they didn't have the amount, and therefore they had to beg for treatment to start, and finally started. So that's already a secondary delay there. And even when the baby had died, they couldn't take the baby home without paying the balance of the bill, which typically, again, they would not have access to this. So we are finding that a lot of the deaths are preventable. And this slide is very telling. Of the 210 cases, 76.5% were clearly indicated by the decode panel to have been preventable, i.e., had we done something differently, this child would not have died. There's another 16.5% where possible maybe to have prevented it. So you have about 93%. So 9 out of the 10 deaths that we are enrolling could have been prevented, but at least 7 of them definitely could have been prevented out of every 10. And then we asked the panelists to tell us what we have done to prevent these deaths. And it ranges from on the top clinical management of the cases, more than a third of the cases, antenatal care being improved, health seeking behavior, accurate and appropriate education, nutritional support, IPCs, and then HIV treatment. But I always find it interesting when I speak to my ministry colleagues to highlight this 50%, half of the deaths, again, in terms of numbers, half for malnutrition, half now, in terms of what we could have done to manage, for example, recognize and manage the malnourished kids, but also, proactively during prenatal care to identify potential complications and be able to manage those during the perinatal period. What we are doing is to walk through what we call a CHAMPS Advisory Committee and Forum, which is a committee that's set up by the government that works with CHAMPS directly. That panel tries to take these recommendations and then try to use them to reduce mortality. That comprise of CHAMPS co-directors, senior MOHS, Ministry of Health representatives, the district health management team, and the hospital staff, as well as the implementing partners for CHAMPS and representatives of national and international NGOs. And the idea is that they will provide guidance to the Ministry of Health to prioritize action, because again, you can't do everything. You have to think of what's most important. And they provide strategic advice and recommendations on queries about CHAMPS and how we expect the program to evolve, and then monitor the implementation of any actions and identify. This is one of the meetings of the group where I was making a presentation at the bottom right here at the Ministry of Health. And we held a CHAMPS annual advisory forum last year that convened all the players, both at the national but also local levels, including politicians like the mayors and the city council members, to address the question of, now that we've seen this data, what can we do about it? We had working groups that came up with key recommendations that we've organized into goals that we're now pursuing funding to implement. Goal 1 was to improve the quality and uptake of ANC services. We believe that improving those ANC services at the facility level will improve their quality, but will also Objective 1.2, want to improve community awareness and demand for ANC services. And we want to be able to use the learnings from CHAMPS to contribute to review and update of the national policy and guidelines on ANC services. Goal 2 was to reduce the incidence of stillbirth and neonatal mortality. So this is really clear around the perinatal period. And we are working both, again, at the community level, but also ensuring that delivery is attended by skilled birth attendants. And in goal 3, want to reduce the incidence and improve the management of malnutrition. Again, healthcare recognition of malnutrition is important, but also how we manage those, both at the community level, but also at the city level. And finally, want to improve management of critically ill and hospitalized under 5 children in selected health facilities. I did mention in the past that it's great to have this cause of death data in terms of specificity, but outside of the autopsy findings, systemic issues at the local level do drive a lot of the mortality. For example, CHAMPS provided accommodation for 2 newly posted medical officers who we expected to better cover the maternity and pediatric wards, but couldn't move because they just couldn't afford to pay. And the government had no accommodation for them. And if they didn't have that, then the maternity is unattended, pediatric wards are unattended, and children die. Having utility support for the regional hospital, paying for water, electricity, providing fuel for the generator might look very primary, but if a child is on oxygen and then there is a power cut and the child dies, to that mother, the cause of death is lack of power. And even though we could find some other reason why that child died, I think the truth is, had there been power, the child may have survived. And so while the autopsies are important, these systemic issues need to be addressed. We also frequently have to do ad hoc repairs and maintenance, like the water and plumbing systems, including IPC. There was no running water during COVID. For example, we had to make sure that that worked. Repairing electricity and mortuary fridges and air conditionings. And then capacity building, this is ongoing. Our team frequently engages with the lab, the clinical staff, and the research staff at the local level. We continue to plan other activities like reestablishing monthly clinical reviews, supporting the quality improvement team, providing support for emergency drugs, because like you saw in those examples, if there are no drugs, then you lose another 2-3 hours between the mother finding the money and then buying the medications, and sometimes they are of low quality. So we're really prioritizing the special care baby units and the rescue units in order to be able to provide that first or second dose to get the child going. And then we are really working hard, like we're doing today, to disseminate the CHAMPS findings at both local and national, international levels, because we think it's a capacity building opportunity, but also it's some kind of pre-service and in-service opportunity for the training. And then round up in terms of looking ahead. So in 2022, we want to start more work on additional data to action interventions. We want to implement some of the interventions I've just listed out to reduce child mortality, and we are collaborating with the National Public Health Institute and the Ministry of Health. We will continue to support the lab here. For example, the CHAMPS histopathology lab is the only functional histopathology lab in the country, and CHAMPS is helping with equipment, with supplies, with training. We are helping with antimicrobial testing in our lab, and we are hoping that we can collaborate with future funding opportunities to expand that to other locations. We will be establishing additional surveillance systems, hopefully, in our catchment area, a pregnancy surveillance system that tracks pregnancies and links them to care during the antenatal period, but also a health and demographic surveillance system that enables us to better understand the underlying population. And we will, hopefully, the next 3 months, support research on adult malaria using mates in collaboration with our sister project in one of our sites in Bo. How can we collaborate? I think there are many opportunities which I'm happy for us to discuss in the Q&A section, but I certainly hope that you all can subscribe to our CHAMPS Sierra Leone newsletter. This is an example of a recent newsletter where we provide frequent updates to our collaborators. there are many working groups, and as Dr. Cheedy was saying about his work on sickle cell, we are beginning to lean in on that. His team actually trained our team, I believe it's 4 or 5 weeks ago now, on sickle cell disease, especially because our team members take back the information to the families. I wanted to understand from Cheedy's group, Dr. Jaja, that we were very clear on what the results mean for families. There are many other working groups that we are establishing, and we hope that people can participate in those. There are data to action funding opportunities, both within CHAMPS and maybe within USF. These are basically interventions to reduce mortality that could take advantage of our findings. And on the bottom right, obviously, I'm sure there will be interest with joint research, joint thesis, work, joint publications with other students and or faculty. That's really the end of my presentation, and here is my contact information. You can certainly get it from the organizers, but I'm really excited for the opportunity to come and have this initial discussion and looking to see this evolve into greater collaborations. Thank you very much for your attention and your time. Over.
Dr. Ike, that was an excellent presentation, and as usual, you never feel you never disappoint. Okay, so as the moderator, I'm going to take the privilege of asking you a question that I was just dying to ask you as you going through your slide. Okay, so my first question is: have you been surprised by any of the cause of death in the CHAMPS data?
Could you repeat that again? Sorry, you were breaking at a point. Say that again.
Okay, so have you been surprised at all by any of the causes of death in your data?
Correct. Thanks a lot, Cheedy. I would say that coming in, I was a little biased. Obviously, I was looking to see a lot of infectious causes of death. I also had been involved while I was in WHO, some of the GBD work, global burden of disease work, and clearly malaria, pneumonia, and gastroenteritis always top the list. And so I was shocked, actually, to see the proportion of deaths that are being caused by malnutrition. So, like you said, it's a poor community where we work, but it's also agrarian, which means they go to the farms and they have little chickens and, plant yams and potatoes. And you wouldn't expect that there would be such a high level of malnutrition, but there is. So to me, that has been one big surprise to me, and I have been engaging with many of our partners locally to discuss how we can turn this around. It's going to be multifactorial. Economic is one, but actually knowledge, cultural practices will be another in terms of what parents give to their children. And for example, if you killed a chicken at home, would you give some of it to the child? If you had an egg, would you give it to the child? Would you give it to the husband, for example? These kinds of questions have cultural connotations. And yes, to me, that would be one big surprise, the contribution of malnutrition compared to infectious causes. Over. Okay.
There's a question on the chat box that is very germane to your recent response. And the question is there a trusted mechanism to accept monetary donation to combat families being turned away because of inability to pay for critical care? I know that CHAMPS seek to address the issue systemically, but while this intervention are being advocated for, is there a way to get funding to families to decrease death on a case-by-case basis?
I think the question has, in my mind, two parts to it. Is that trusted mechanism, right? And then the case-by-case basis. So I will take it into two parts. In terms of trusted mechanism, I do think that if this was something someone was interested in, we can work with you to find a partner, local partner that we can work with and channel those funds and make sure that they are well monitored and well accounted for. I know that CHAMPS, we have our eyes and ears on the ground where we work at the district level. And I do believe that our team members, many of whom I believe are on this call, could work with someone who was interested to find a way to close this gap. And then the second bit of it in terms of case-by-case basis, we really therefore require presence on the ground when these mothers show up. What we are doing the emergency drugs, for example, is again to avoid all the corruption and losing, medications. CHAMPS is trying to manage that with trusted doctors. So we have doctors in each of those centers, the SCBU and the resus unit, that will be handing these medications to, and to be in a locked cabinet. And there will be a form that they will complete. So as they use these drugs, they fill out the forms, and we track exactly the level, so that when they go below a certain level, we're able to restock, but then we're able to sign off based on how many have been used and for which particular patients and individuals. We are looking to have some kind of revolving mechanism where when that mother finally comes back from shopping for the drugs, we can replace them, but we also know that that could be really tricky. And so for this or that mechanism, so in terms of case-by-case basis, it has to be a way for CHAMPS to support that process, and we'll be interested in having that offline conversation if someone is interested to do that. Over.
Okay, very good. There's another question on the Q&A box that asks, Dr. Ike, is your data collection of stillbirth across all of Sierra Leone? And if so, how do you learn of the death that occur in very remote communities?
For the first part, you said?
I guess the question I want to know if the data collection is performed across Sierra Leone or
Okay.
Okay. And how do you get knowledge of death that occur in very remote areas? Okay.
That's great. So, so first of all, thanks for that question, because I think again in a 40-minute conversation, I had to remove a few slides where I could have gone into the details of the catchment locations and all of that. But bottom line is, this is not across Sierra Leone. This is a very small location. So there are 16 districts. We collect data only in one district, and then in that one district, we collect data only from 2 chiefdoms. So each chiefdom has average of 50 to 100 communities. So it's not a very large catchment area, okay? But within that, and that's the second part of your question in terms of how we collect information from deaths that occur in remote communities, we have a network of community reporters. So these are individuals who have been selected by their communities because they are either respected or knowledgeable or literate. They may include retired teachers or retired, health workers, or sometimes current, health workers, community health workers, for example. And we have brought them for training at the urban center. We've, educated them on how to collect these kinds of information, and we give them our active phone numbers. And so when there's a death in that community, within 24 hours, they pick up the phone, they call the CHAMPS team, and we're able to react quickly to go and pick up that body for autopsy. So we have a network in the communities and in all the health facilities, including the primary healthcare units, for example. And this is how we operate. But this will be difficult to replicate across the entire country, obviously, for logistical reasons. I would answer the question. Back to you, Cheedy.
Okay, very good. So there's another question that asks, Dr. Haig, how would you prioritize intervention based on this finding of causes of preventable mortality? Or would you intervene at different levels? So how would you prioritize intervention based on the findings of causes of preventable mortality?
I think this is the hardest question that we have to grapple with as CHAMPS, and this is not just in Sierra Leone, but also at the other 7 sites. And we engage frequently with our program office in Emory and with the Gates Foundation about what do we do now. Bottom line is that CHAMPS is a research activity, and most people on this call are, research-oriented people, either in terms of core research, but also implementation research. The difference for CHAMPS is that there's always a built-in interest to be able to intervene to then control the findings. So we are trying to reduce mortality based on what we find. Making that leap is difficult. For those who are working in global health, it is very challenging. The best way to do that would be to get people in government within the Ministry of Health who are interested, but also who are resourced to do that work, because there's no way one project can do that. But we're approaching it in multiple levels, and that addresses your question, which is there is work that CHAMPS can do based on our funding and resourcing, and we are doing all of those. I gave a few examples, but there is work that needs to be done by the Ministry of Health, by the government, And there are some of those that we cannot do anything about. We have to get them engaged and involved. But there are also partners that we're collaborating with. So we are reaching out to partners locally, NGOs, etc., who are interested in different pieces of the work. And we're beginning to see success in how they engage to resolve some of those issues. Over.
Very good. Very good. So here I have an ethical question, Dr. Ike. I would like to know how receptive have families and community been to CHAMPS conducting autopsy. So basically, how receptive have the community been to CHAMPS doing minimal invasive autopsy from a cultural as well as from a religious perspective?
Yeah, that's really helpful. And I see someone else is raising their hand, but I'll leave it to you, Cheedy, to be able to decide how you prioritize these questions. But I think it's a really important question you ask. And there has been a lot of research done, not just in Sierra Leone, but in other sites, to try to understand how receptive families would be to autopsies. Firstly, because culturally and sometimes religiously may be prohibited, but also because you have to ask yourself, to what end? Why would I submit my body to be, handled or malhandled following death? And in Sierra Leone, because we have been very lucky, we have a local NGO, Focus 1000. It is owned and run by locals who understand the context, who have lived in the community. We're also working with a mortality surveillance team, World Hope International, though they're an international NGO. They have been in our catchment area for more than 40 years. And between those two, we have been really lucky that the engagement with religious leaders, with cultural leaders has resulted in a very, very high level of acceptance. Remember, this is a very poor community with a very strong Islamic leaning. But with the combination of all the conversations and opportunities that have been, engaged in terms of reaching out to them, we are getting between 80 to 95% consent rates throughout the period of implementation. That has been one of the highest levels of consent across other sites, in spite, again, of these cultural and religious biases. Over.
Okay. Thank you, Dr. Ike. So we have a question all the way from the Ministry of Health in Sierra Leone from Dr. Jawad. Okay. So Dr. Jawad wants to know why there ain't, whether waterborne diseases could be a cause of under 5 infant mortality in your data. Or is waterborne diseases a cause, one of the causes for under 5 mortality?
Okay, so I know we're almost out of time, Dr. Jawad, but I'm happy to engage. Yes, go ahead.
Hello?
Go ahead, Fode.
Yeah.
Okay, Dr. Jawad, go ahead.
Yeah, yes, how are you?
Pretty good.
I'm doing well.
Yeah, let me start by thanking you for the great job you are doing. I'm the current Minister of the Environment in Sierra Leone. I'm actually an associate professor here at USF, Public Health. Right. So I'm presently in Tampa. I came for a meeting in New York and decided to swing by to see my family. And I went to the college yesterday and I saw this information on Friday. I saw this information. I said, oh, this is good. I have to attend. I need to engage Dr. Ogbuanu and also Dr. Jaja. Now, the question here is, I know the issues you're talking about. I live in Sierra Leone. Some of these areas you went are even far better off than areas, say, for example, in Falaba, in Karine, in Kaila, and other very remote areas. And the issues are really not different, but they are more severe there. So my question here is, I didn't see much of waterborne disease playing in this. And Ike, you raised very salient points about people going to hospitals, not being able to pay, doctors demanding or health professionals demanding payment before they are treated. That is actually true for those who are listening, because we as a government inherited a collapsed health system. But thank God, this is now improving, as you can see. When I went to Sierra Leone in 2018.
Dr. Jawad, I will have to interrupt here because we're out of time.
Okay.
But this is a conversation that we will continue. I'm personally going to look here while in town, and we'll continue this conversation in Sierra Leone, because what we're trying to do with this series is to showcase Sierra Leone and the opportunity that are available for USF to have a footprint in the country geared towards health system strengthening and capacity building. So we'll be definitely happy to continue this conversation.
I will engage you further. Thank you.
So, Dr. Ike, thank you so much. And I would be amiss not to mention to our listeners that USF has fully executed general agreement, or what you call MOU, with the main medical university in Sierra Leone, and also the Postgraduate College of Nursing and Midwifery. We are also working on executing MOU with the CHAMPS program, whereby our faculty and students could have access to CHAMPS data for secondary analysis. So I want to urge folks that were presented today to engage or think of possible ways in which you will want to make use of this data in your research. So I thank everybody here today, and we look forward to seeing you again in future presentation. Thank you so much.
Thank you.
Thanks everyone for the opportunity, and looking forward. Bye.
Okay, bye everybody.
Thank you.